how pathophysiology, when you started it, what the step that the body suffered from when you get your stroke. And then I will point out the symptoms and signs. What does the people with stroke look like? And then we'll talk about some diagnostic the tools to evaluate people with stroke. And then we'll have the treatment that include the real treatment of medical treatment and the rehabilitation treatment. And at the end, we'll see how to prevent stroke. So let's go through that. The brain. The brain is, um, you know, I'm not sure how many of you have seen a brain, but the brain is com- composed of the cerebrum. Cerebrum here, the big part of the brain is called cerebrum, and the posterior in the back of the brain, right here, is called cerebellum. And this one is like a stick that holding the brain called the brainstem. The cerebellum is the largest part of the brain and responsible of function, including the thought, the action, the sensory, and the cerebellum here is about controlling the balance, coordination, and fine movement. You see, if someone affected by cerebellum, you cannot point your nose like this, you know, anywhere. It's very balanced. Cerebellum. The brain, the thought, is talking about the function. We'll get into that a little bit more details. All right, so the brain, the cerebrum, as I mentioned here, is the largest part of the brain and it cut in half. You know, like someone have the hair this way, the brain underneath it also has two parts, left and right. So it is the part, the front corner. This green one is controlling your speech, the personality, problem solving, intelligence, judgment, concentration. If you have someone that very good in organizing things, that is come from the frontal part of the brain. Those are the personality, the mood. Sometimes I mean the uh, coming from the front part. This is the high function, intelligence. And then the parietal part, the side, the top and the side, there's two of them. Those are the part of the brain that is responsible of heart, temperature, pain, spatial awareness. So the brain from the side, those are in charge of those type of function, motor function. So we'll move to the next part. The brain has, uh, I mentioned, the big one, frontal, parietal, and occipital lobe. So those are this front located in the front of the brain. Your head, it's maintained, as you mentioned, about the judgment and the intelligence. This also maintained about the motor function and skills. And the pons here, here is called the medulla, and there is the pons. There is lots of small nerves coming out of that. That the cranial nerve that is in charge of the facial movement, swallowing, the eye movement, and so on, come out of the pons and the medulla. And so the medulla has the brainstem situated there. The brainstem is controlling your breathing, your respiration. So you cannot control that. It's just voluntary. It's just automatic controlling the way you breathe and the way you function and heart rate and heartbeat and vomiting. If someone, I've seen someone, a friend of mine, there was a strike in the town and the police hit him right there. What happened to him? He could have been stopped breathing, but he vomited non-stop, vomited non-stop to that. So Part of these two here, above the cerebellum, the occipital lobe, where the vision is, if you get hit there, affected that occipital, you may not able to see or see part of the sight. So the brain has function that very specific, depend on the location of those area. And so uh, one, parietal, occipital, cerebellum. Cerebellum is equilibrium. Each um, coordinate the motor function, the ability to move, and the spinal cord, where the nerves comes um, uh, out to the limbs. So it coordinates that balance. You are when I have a leg up this way, the cerebellum say you are about 2 feet up the plug, and in a very short period of time, the body able to coordinate that. So when you have stroke, we have about 800,000 people in the States have stroke a year. That's quite a bit. In a year, we have 800,000 people have stroke in the States. And the second leading cause of death worldwide, leading cause of serious long-term disability. People with heart attack might die, or if it doesn't die, may survive and work functioning well. But people with stroke may carry on some disability for lifetime. So that's why we need to be very well acquainted with stroke to prevent it, because the disability of it, the bloodless stroke, I say the stroke, the blood flow not get into your brain. That is the majority of 87% of the stroke coming from the bloodless. The brain does not get blood flow. 13% of the stroke coming from the blood that is flooding the brain, which is hemorrhagic bleeding type of stroke. So those what we have. Now, there are some risk factors what cause the stroke that we cannot modify. We just like that. For instance, age. Stroke double after age of 55. The risk of having stroke double after age of 55. And two-thirds of all stroke occur with people age 65 and above. So when we have 60 years old, then the risk of the stroke is double. See? And so as we get older, then the risk is higher and higher. Gender, male has higher risk of stroke than women until age of 85, and then they'll have the same risk. Female has protected factor because of the estrogen. Men doesn't have it. But once female become menopause, then they will have the same risk. You see what I mean? Race, African American and Asian have a higher stroke risk and mortality compared to the other ethnic group. Family history, someone who have family of stroke, um, grandparent, parent will have higher risk of stroke as well. These are the factors, the risk of stroke that we can modify. If I'm African American, for instance, I cannot change myself. If I'm a male, I cannot change myself. That's there. But there is something I can change. For instance, hypertension. People with hypertension, high blood pressure, have a risk up to 4 times risk of stroke than people with both hypertension. That's why we'll talk about hypertension in 2 days and cardiovascular, because everything high blood pressure is a risk of heart disease and especially stroke. 4 times of risk, and blood pressure above 140/90 significantly increase stroke risk. So we need to work on those blood pressure, because the high blood pressure recorded silent killer, silent killer. Diabetes 2 to 4 times have increased risk of stroke. Why? Because diabetes affect the vessels, the blood vessels. And those blood vessels can be plugged and be irritated, and that's why the blood flow to the brain is affected. So if you have diabetes and hypertension combined, then it's not good because those are two risk factors that very alarming. Then we have smoking. Smoking not only affected the brain and blood flow, but also affect the arteries in the legs. And so smoking tend to irritate and injure the lining of the blood vessels. And when you are get injured, there will something platelet and other coagulation factors stuck there and causing that lumen of the vessel to get plaque. So smoking is risk factors that we can change. And other modifiable factors are obesity, high cholesterol, atrial fibrillation, or those heart rate that is up and down. Okay, so here are a few of them. As I mentioned, high blood pressure, obesity, lack of exercise, sleep apnea, high cholesterol, um, cardiovascular disease, and risk of having smoking. Okay, let's move on. We mentioned about high blood pressure. We need to check your blood pressure to be below 130/80. And 128 is good if you have diabetes. So diabetic have a higher risk, need to have lower blood pressure. Now we have this diabetes insulin resistant people with the insulin does not help their blood pressure as their blood sugar to drop because of something that you eat or some obesity. The fat does not respond to the insulin, and insulin can accumulate in the body. You have more insulin. The insulin is a growth factor, and the body can gain weight and more resistant. It's like a very hard to treat. So the way to treat it is to be able to reduce weight, exercise, so the body will accept insulin, the blood sugar will drop, and that is what we aim to do. Now, the risk of diabetes and complication is so many: stroke, heart attack, peripheral vascular disease, diabetic eye issue, blindness, glaucoma, um, kidney issues, and all of that. So that is just aside from stroke, but we are talking about stroke today. Stroke, a stroke is referred as the vascular accident. I mentioned the blood flow is interrupted uh, in the brain. We call it brain attack, cerebral hemorrhage, cerebral infarction, and ischemic stroke. There's a different name, but the most important part is the blood cannot feed the hungry brain. All right. So what we call when we ask the history of people we may have stroke and say, "Hey, when did it happen?" The onset of it, huh? The timing and the progression. There's a called transient ischemic attack. Somebody who had stroke for just 1 hour, less than 12 hours. Oh, his mouth was twisted for a while and now it's better. That is just a temporary stroke. That is very alarming because it will come back, if we don't take care of it. Review the risk factors, the medical history. Is this patient, this man, is he smoker? Is he have hypertension? Does he have diabetes? And then check the blood pressure, then do some evaluation about the consciousness, about the orientation, who is the president, what did you eat yesterday, where are you now? All the function is both legs the same strength, does the feeling the same in the left and right? Is the patient able to walk with good balance? Then you have this stroke scale and say, hey, these are the minor stroke, these are the moderate stroke, it has severe stroke, and so on and so on. We have the evaluation with diagnostic. The most important first, because it's really quick and gives some information at the emergency room, is the CT scan. The CT scan will show some area of if it's a hemorrhagic or ischemic, it will tell you that there's a bleeding in part of the brain, or there is some area that is looking diffuse or no blood flowing. So that's the CT scan will help distinguish the bleeding or the parts that no blood flowing. Okay, MRI can be done. It will help, but it takes a while to get that done. And then MRA is the examination of the vessels that supply the brain. It put contrast in it, and it should um, follow the path of the uh, brain vessels, and you can see interruption or bleeding or so on. And so the test is to see the coagulation, the bleeding, the stadio both electrolyte and the blood count, and says this patient has a risk of bleeding or not. Is the platelet there, the bleeding time, and then also check the glucose, lipid, and cardiac enzyme, and see if the patient is someone has high blood sugar, low blood sugar, hypertension, low, and so on and so on. Then we can take a look of the heart, the atrial fibrillation there. Is the heart in good rhythm or not in good rhythm? Is there any clot in the heart? Because those clots can spread and get to the brain and block the blood flow in the brain. All of that is necessary, as I mentioned. Here is the MRI, here is the CT scan, both short bleeding in the brain. Now, what caused the bleeding? As I mentioned, it could be from called thrombosis. This is local. The blood flow is plugged locally. The artery get narrow, and then the blood flow is blocked, and that is can be from blood clot. It can be from atherosclerosis. Is the blood flow, the blood vessel getting tight and tight and tight and tight. The lumen is getting narrow, so it doesn't have enough blood flowing to the brain. Or it could be from hypertension, diabetes, or smoking. When you have hypertension, the lining of the vessels getting stiff and stiff and stiff and tight, and not enough opening for the blood flow. And those are contributed to about 50% of all stroke. There is another uh, diseases that cause interruption of the blood flow, bloodless stroke, is from recorded emboli. So for instance, someone has problem with the heart, atrial fibrillation. When the heart pumps blood, there may be a small clot coming from the heart, travel up to the brain and block the blood flow in the brain. So the after in the brain may be okay, but because of this emboli or this clot that is traveled from the heart to the brain that interrupt the blood flow in the brain, and that is stroke, especially younger people. So those are reasons. The other cause of the stroke are the bleeding stroke. The bleeding stroke, bleeding is that the bleed directly affected the brain, often caused by hypertension. Someone that really or aneurysm in the brain, malformation of the blood vessels, and just pop and bleed. And so someone who have some issue, stress, blood pressure went up so high, and the vessels in the brain cannot control that pressure and ruptured. So the blood get into the brain and the nerves in the brain. This one cause early mortality higher. The bleeding stroke cause early mortality. The death can be very quick. However, if someone survived that, the people who have bleeding stroke do well than the people who have bloodless stroke. The reason is the bleeding stroke is very localized. Once that removed and taken out, the rest of the brain is good. The people with bloodless stroke, it becomes diffuse, and it's not as acute, but the recovery and outcome is not as good as the bleeding stroke. We call it subarachnoid hemorrhage. The brain has covering, and this covering of the brain, the blood can also rupture and get into those chordic meninges, and most commonly ruptured aneurysm. So those are some malformation of the vessels there and lead ruptured and cause this subarachnoid hemorrhage. One of the signs that we can see on this is headache. People say, my head is hurt, it's so bad, the neck is stiff. You know, those people who have sudden onset of headache, you need to check it because it could be a stroke, bleeding stroke. Okay, next one, pictures. I wonder if you can see. This side is the bloodless stroke. The blood flow is interrupted here. This brain is dead. This is the brain cut this way, one side to the other side. This is a stroke, bloodless stroke. You know, can be deep, small vessels deep in the brain is therapy locked, and this part deep in the brain is gone, dead. Or this big arteries, MCA, is blocked, and this part is dead. These are it bloodless stroke. Okay, and here is bleeding. Some ruptured small vessels cause deep bleeding, deep small bleeding. Or it is a bleeding coming from big arteries and bleeding covering the nerves of the brain right there. So those are happening. As we mentioned, those are different kind of diseases, but it can create if you have multiple small stroke in the deep brain, uh, you can have those multiple dementia. People start dementia, they cannot remember stuff, and as you get, those are stroke. Dementia is from stroke that happens slow from the multiple fact dementia. Memory is gone slowly, and this also can have this stroke that we mentioned. Um, Mixed dementia, and also just the big shock that we encounter every day is that sudden loss of function. Those are come from big artery that is blocked or a big vessel that is bleeding. So it looks like this. The bloodless stroke, ischemic stroke, is a stroke that you can see here. This part of the brain, all of it, are affected ischemic, in fact. And so it could be from arteries there that is um, not enough flow because of hypertension. It's tight. It doesn't have enough flow for the blood to to irrigate all of those area of the brain. Or you can mention about this clot that travel from the heart or from other part of the body and plug that arteries. Or it just hyperperfusion. Someone who has bleeding, accident, bleeding somewhere we have shock, then not enough blood that travel to the brain, and it can cause stroke. There is some other problem that people may have is this type of let's see monoxide poisoning. Not it's um, carbon monoxide that the people breathe and then affect the whole brain because of the blood is not good, not enough oxygen. So here we have the same here. This is the big artery bloodless stroke, MCO occlusion blocked somewhere. Part of the brain is gone. And here is if that instead of bloodless, it's a bleeding, and part of this brain is affected. So um, it did affect the carotid, whole brain is affected, and so on. This is anterior cerebral artery, middle cerebral artery, and middle cerebral artery. Depends what type of artery is affected. Now we can see the bleeding hemorrhagic shock. When it's bleed, it looks like bleed on CT scan, bleed. You know, it could be inside the brain itself, It could be subarachnoid bleeding inside the cisterns, and also it can be from malformation of vessel. We just mentioned about this, the blood flow. The blood flow normally about 50 to 60 milliliters per minute. And so the brain requires constant oxygen and glucose. Glucose and oxygen, the brain needs those all the time. Interruption of those oxygen and glucose from low blood flow is a problem causing stroke. When we have this blood pressure, when the blood pressure is high, the brain tries to auto-regulate it, change to adjust that blood flow, and so it will reduce the blood flow. This change in blood pressure we have is trying to adjust that, so just what the brain needs. But that type of adjustment is why the blood pressure fell to 60 or right about 160. That type of auto regulation is not working as well. So if someone lost some blood in accident so much, then the brain cannot adjust that much. If you have a high blood pressure so high, then the brain cannot adjust it. So that's an issue. And then when you have this type of bleeding, then you have a cascade uh, of uh, of a brain that is suffering, of a brain that is suffering. There is some toxicity, some stress, some energy failure, and then a cascade of problems that people experience. This hemorrhagic stroke, uh, it's the blood itself. When you bleed inside the brain, that blood itself is irritating the brain itself, the brain cell. And just that itself can cause quite a bit of headache and so on. And then when the blood is getting there, it doesn't stay. It's always accumulated and become a pressure, become a hematoma, and that a direct pressure on the brain. So that is a mechanism. After that, when the blood is accumulated, it put pressure, and then we have this type of vasodilatation. So the blood does not maintain its protein, its fluid in the vessels. It come out and create more fluid in the brain, edema, and that type of edema is create more inflammation, and people with bleeding stroke, that is about in 3 or 5 days that become a maximum. And those are when that so much pressure from the bleeding, it can push the brain down into the neck and causing that pulse to be compressed and stop the breathing and heart rate. So this increased intracranial pressure that I mentioned here reduce the perfusion and then the risk of herniation. Herniation is that the brain get into the tight spot here, and so herniated, and you're not able to breathe. So those are some issue. I mentioned about blood-brain barrier. Normally, here the blood flow, there are cells covering that blood flow, but if there is some bleeding, there are some plasma come out of the blood and kind of um, flooded the brain with water, flooded the brain with water. And so it damages lots of structures. And as I say here, here's the blood vessels. The water and the plasma get out of the blood, and they made all these neurons, astrocytes, microglia. It's backed into a cytotoxic. Um, Cells get irritated because of the inflammation and cascade of problems, and that makes it worse. It's not only the bleeding, it's not only the bloodless, but the reaction of the body because of this sapolene create a secondary pressure, secondary attack to the brain, and cause the brain to really suffer within 3 or 5 days extra. Now, um, talk about the small vessels. The small vessels, These are affected by small vessels. There are tiny vessels in the brain that gradually interrupted and no flow in it. And so this become a lacunar effect, microbleed, and so on. So the people, this is opening. If you lose cells around that, lose cells, that become a big open of cavities because the cells around it are gone. And not only there, but it's um, affect lots of functions such as memories, affect function like understanding and all of that. So 25% of the stroke worldwide has some cognitive decline in elderly. This the small artery that is affected and created balance issues, memory issues, maybe incontinence, and all of that. Now, these are the small vessels I mentioned. You know, these tiny vessels become interrupted at the deep part of the brain. So this deep part of the brain is affected. We can see in the eyes. The eyes have the small vessels, and what we see through the eyes is happening in the brain. And so when you look at the front of the eyes and see this is normal, clean, like a moon, beautiful. And so this is the eyes fundus at the back of the eyes. We have some exudate, the kind of you see those kind of water shade, flame. These are all bleeding, small bleed or bloodless tissue that suffer from lack of irrigation and change to be suffered. This is the fundus of the eyes. And see what we see and the fundus of the eyes, it's happening inside the brain. So if we have ophthalmologists, they look at your eyes and look and say, your eyes is so pristine and nice and clean, means that possibly your brain inside is really good as well. How does the stroke patient appear? We have this called FAST, 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 face, face drooping. You have seen those? Drooping face. Huh? Ask the person to smile. Smile, show your teeth like this. Then one is not symmetrical. Droop. Have to smile, then it also doesn't. One face is not there. Yeah? So that is the face. One side is drooping and so on. And one face is not ill. Okay. Then arm. Huh? Face and arm. One arm is like this, weak. The other is good. And so speech. Huh? Difficulty, same phrase. Slurred speech. Cannot elevate the tongue. And then the time to call 911. So the first is look at the face, look at the arm, and listen to the speech. If you see something that is alarming, 911, 911. Okay? Because of the symptoms. Um, if I mentioned posterior circulation here in the back, I mentioned about occipital lobe. If that part of the in the posterior part of the brain is affected, you have vision issues, you have dizziness, balance problems, difficulty swallowing, posterior circulation. If you have a brainstem, you have corresponding, the part of the area that is damaged is weak. Hmm? So if you have a brainstem problems on the left side of the body, then the face affected is then the right side, and the body affected is the right side. That is brainstem. If it's your cortical, then you have the cross-spinal. If it's affected, but the left side is affected, the finding of problems is in the right side. But in the brainstem, it's at the same side. Okay? So the same procedure for this one, it's ataxia, as I mentioned, You cannot ask patient to sit down, cannot metabolize, just fall. Okay, so those are the start with the eyes kind of move from side to side, and then he has this tremor that is unable to reach the same purpose. You hold them the spoon, they have hard time to reach that spoon. It's not accurate. Okay, so here is what they mentioned, called hemiplegia. If it's affecting the left brain, then the body right side is affected. Paralysis of the arm and leg and the face, with blood clot happening in the left carotid, then the right side of the body, it is all affected. If we have someone affected by stroke on this side of the brain, then the facial droop affect the left side of the brain. If it's the brain stain, then it's the same location. So those are signs of pain. We can see this gentleman is been stroke, facial droop, and weakness all in the left side, all left side. Typical type of the stroke. This is stroke that's not recent, that patient who had stroke for a while. Recent stroke patient cannot stand that well. So we have either the whole left leg side, or just the hand, or just the leg, depending on location of the stroke. Someone, most of the stroke, if they able to walk, usually affecting the middle cerebral arteries, patient may be able to walk, but having trouble with the hands. And this is also just a different part of the brain. More affected in the arm and more affected in the leg. In the anterior cerebral arteries seems like having problems in the lower limbs. And not only the weakness, but swallowing, have a difficulty. Swallowing, we take it for granted, but swallowing is one of the most difficult things to do. We don't think about it, but the body and the brain has lots of coordination about swallowing to make that food get into the right directions. So here is the time of treatment, time windows. I mentioned here, time is brain. We have about 2 million neurons lost per minute to instruct how many millions? 2 million of neurons, nerve in the brain can be lost every minute. So time is a brain. Uh, so the treatment need to start within 4.5 hours of onset. If you have someone that has symptom of stroke, take to a doctor's emergency room, get the treatment start as soon as possible, because time is brain. And so if they cannot resolve it with medication that will dissolve the clot, they can put a small tube to remove the clot, need to be done within 24 hours. Emergency department and all of that. Treatment is blood filler, but we need to know exactly that the stroke is not bleeding. This is the stroke. Most of the stroke, as we mentioned, 85% is bloodless interruption of the flow because of the arteries not open enough. So that's why most of the stroke need anticoagulant blood thinner that need to be administered within 4.5 hours. And we need to make sure that this patient did not have recent surgeries, did not have active bleeding, and so on. So this lead to life-saving uh, blood thinner, and then also get some catheter into the blocked arteries to open up that arteries and put a stent or something to make sure the flow is good, and then continue on a platelet and so on, blood thinner for maybe lifetime. This is for bloodless, that brain that is suffered from lack of blood flow. And when we have a bleeding stroke, this is a different approach. most of the bleed in stroke come uh, on people with high blood pressure. So the blood pressure control need to be checked, need to target that blood pressure. That's what you need to do. If patient has a blood thinner, need to revert that blood thinner because it create more bleeding. And as I mentioned, when you have this blood into the brain, creating edema, fluid that pushing the brain. So we need to have some management to control the overflow fluid and compressing the brain and so on. And it may need to have surgery, just open part of the brain, the scope to give room for the brain to expand. And those are important. Most important is to control the blood pressure if you have bleeding stroke. And so stroke rehabilitation, that they measure what to do when someone has stroke, rehabilitation, the comprehensive guide to restoration. Prevention is great, but if you didn't able to prevent, rehabilitation is the key. Most of people, the short treatment of stroke is very short. I mean, very limited you can do. Most I need to get it done is rehabilitation. So rehabilitation require physical therapy, occupational therapy, speech therapy, and nursing and cognitive rehabilitation. Just get into this little bit. Physical therapy is the main it's the mobility, strength, and balance coordination. 12% walk, 12% use the arm, and so on. Occupational therapy is to help with the activity of daily living. So we'll get into those. The recovery journey is within the first 24 hours, 2 weeks, medical stabilization. Just make sure the patient is first 24 hours hyperacute. Just fight for life. Then 1 to 7 days, you have this make to stabilize, find what caused this, the heart, the lungs, and so on, and treat those preventing from having it again at the same time. The subacute 2 weeks to 6 months is your time active rehabilitation. And then later on, the rehabilitation can continue, but the improvement is not as um, it's gradual. It's not as uh, quick as in the beginning. So shock, severity, and vocation, and so on. Rehabilitation, the sooner is the better. The outcome is better as sooner as you started. The reason is because of neuroplasticity. Neuroplasticity is the ability of the brain to reorganize and adapt the structure. So the cell that was injured, it can heal and adapt to the new circumstances. And some of the cells that was not affected can take over some function that it didn't do before. So that reorganization and neuroplasticity, especially in a kid who had stroma and can really adapt pretty well. After 40, it's pretty tough. But this is the neuroplasticity mechanism is that there is some a lot of mechanism. I think we don't need to learn about that, but it is some cells taking over tasks that never done before. And some of the cells that affected learn new tasks. And that will happen within very short period of time. And the therapy is helping that. If you move a hand like this in physical therapy, the brain that corresponding to that arm start to think and say, I can move. The brain reorganize with this movement and these activities and heal. So it's not the brain to the hand anymore, but the hand to the brain. So it's very important that someone who have stroke, especially, the thumb is very good science, able to move your thumb. The thumb occupy big part of the brain. So someone who moved the tongue after a stroke has a very good sign. Move the tongue. And it's not even helping this patient to move his tongue, some effect on the injured brain. Okay, neuroplasticity is very important. The role of physical therapy is taking advantage of that neuroplasticity, the flexibility of the brain to take new function, to reorganize, to heal, and to restore. So the goal of physical therapy is restore motor function, improve balance, prevent complication, contracted, and enhance dependence. Somewhat, if you have this stroke like this, those can be treated early on. Otherwise, it's getting tough and very difficult to straighten it again. All these fingers, kind of like this. And it's very difficult. We use Botox injection and all kinds of things. But early treatment enabled this hand to do this, do this, and, you know, kind of, it can be like this. So early rehabilitation, walking is very important. Stroke patient has difficulty with ambulation. Um, they need sometimes a brace because our foot drop, and so those are requiring lots of training. And the early on is the better for people with stroke. This is a patient who may have cerebral stroke, have difficulty maintaining balance. So you need to train the trunk. You sit in and then holding them and you fall this side or fall this side or fall backward. So the treatment is to help this patient maintain that. You can challenge them and give them a ball. They try to reach it, maintain balance. Reach it here, maintain balance. It's improving over time. That patient to maintain that trunk balance really good. That's what you do first. Once patient control the trunk balance, then you can say they can stand up and maintain steady balance and then challenge the standing balance with type of exercises and so on. Most of the time, so they may maintain the strength, but the balance is not there. So we have this rehabilitation. Evidence-based physical therapy intervention is repetitive, repetitive, repetition, repetition, repetition. Because, as I mentioned, promote neuroplasticity. The more you repeat it, the more you repeat it, the brain will follow. The brain will follow what you want. If you don't do it, the brain will sleep and there and not functioning. I've seen it. I have. I was a medical director of the rehabilitation unit before, and I have lots of people that they help having stroke. I have a nun that has cerebral stroke, and she was organist and so on, very well known. And she cannot sit up, she cannot stand, she cannot, she was stable. And we helped her to get gay, and she was recovered completely because of motivation, because of the therapies. This can be done. This is constraint-induced movement therapy. You see, this the good arm kept said. Don't use that good arm. Just use the bad one and repetitively move the scope top. The same. Moving this cup from this side, this side, this side, repetitively. The therapist is watching it, helping it. This patient can make a difference and gain lots of functionality. The contract-induced therapy is trained affected limbs and intensive for 2 to 3 weeks. A strong evidence of that. The same for get training, body weight supported on treadmill. Have some supported the body cannot weight, have a weight just supported on a treadmill, and then just like that walking on a treadmill with weight supported, and then you can move the legs. If they cannot, if they are weak, you manually move those legs. But later on, those legs are getting stronger and moving by itself. It's amazing the body can do to restore itself in physical therapy. Those are therapy rehabilitation. It cannot replace. Medicine cannot replace it. You have to be very consistent with that overground walking. Sometimes you need to get patient to the treadmill with bar, and so on. Okay. Well, this is one gentleman who sweat so much because of difficulties, but hanging on, and the therapist encouraging them, "You can do it, you can do it," and you can uh, recover. The same hands have issues, do repetitive tasks, make a difference for them. Occupational therapy and Asian occupational therapy is helping people to do daily functioning. This is a way of not only the strength of the most of the time is the upper limbs. It's not only the strength but the task. You know, these occupational therapies help people about dressing, bathing, grooming, eating, and toileting. I we have this co-treatment, physical therapist and occupational therapist work together about feeding. Those people, you need to teach them how to get the spoon into their mouth. Help them to get that. Require cask and training. How to get the upper extremity dressing. Put your shirt on. This is the way to put it on. This bird and tie. Train them to that. How to put their pants, how to put the bands on, how to transfer from the chair to a table, how to brush your teeth. It requires a lot of training up there to do that. Help them how to whip themselves. All of those require the occupational therapist to get into all the functional that is very basic that we take for granted. It take a lot of time to get that going. Sometimes you need tools. If patient cannot really do it, you may need to have substitute of a spoon to help them get the right feeding. And so the motor cognitive, so we'll talk about that in speech therapy. But occupational therapy, I mentioned about task-specific training, uh, uh, in country induced movement. You just you cannot use your arm, you just use the weak arm. And mirroring, you have therapy, you have a mirror in front of them, and then in front of the mirror and say, "Follow me, do this, do that, comb the hair, comb this way, no, no, not that, put the hair, comb this way." And it just requiring, they watching the mirror, watching themselves. And so uh, need of those type of adaptive equipment. This is hand is very difficult. The dexterity, your movement is requiring a lot of therapies just to move fingers and strengthening them. Occupational therapy work on those because sometimes they even don't know how to use the hand to grab their pants or hold their shirts. And so, oh, speech language pathology, we don't see them often, but when we have problems, we need one. And those are important. Why? Because the speech language therapist um, assess and treatment communication, not only the talking, but the swallowing and cognitive issue of the stroke. Uh, we have this called aphasia. Aphasia, aphasia is a term of not able to talk. You mentioned just the vocal. No, disaster is people cannot talk but understand everything. Their faces doesn't understand anything and cannot voice anything, or able to voice but does not understand. So, and then the swallowing is unable to swallow. Those things are the speech therapist work on that. If this patient has disaster, just I can't eat now, knows everything but cannot say anything. Is it morning? I can't. So the therapist needs to be patient. He said, "Calm, that's good, good, good. Oh, repeat that. I can't, I can't, I can't, I can't. Yeah, move on." And then you have to hold them for to help them say something and encourage them to continue on and make progress. And amazing when you work with a team to see the progress sometimes slow, sometimes fast for these people with stroke. But once after, that's why we have it intensive rehabilitation. Within about 2 weeks, we do the most we can, and 80% of recovery happen there. And later on, it may take 2 months. After 2 years, the recovery is not much, a plateau. But you can do the most from the time of the stroke. If a patient is in bed unconscious, you work on it right away. Physical therapy, occupational therapy. The people that have the most feedback positive from patient and family are those therapists because they make difference. They know someone legislator, congressman in California, went for a congressman had stroke, and wow, the therapist worked on that, made a lot of difference. They were very appreciative. So the speech, disarty, apraxy, for instance, uh, what is this for? Apraxy, let's say someone who take this and put in the mouth. They don't know how to use it or use the comb to feed themselves or use their spoon to calm the thing. Those are type of, have the idea but doesn't know which one is right to do. So, a problem or unable to play or then have difficulty to coordinate the hands. Those are kind of apraxy, not able to plan or coordinate the movement is an issue. Okay, so here uh, we have what is aphasia. Um, these are a few of them, and say expressive aphasia or brochaphasia is an example of that is when someone, like an individual, use fluent but nonsense doesn't make sense and cannot understand what others are saying. Let's see, it can make, for instance, may say, we call them word salad. What's your name? And with sentence like this, Joshua may the wind, dog, jump, helicopter, cheese on the yesterday's movie. There's nothing there that makes sense. Fluent, but it's just a salad. Or where do you live? We the light red fall down and see you cannot understand where they start, where they end up. That is someone that has cognitive problems, understanding, knowledge, also speech, and someone who have the other type of aphasia called expressive aphasia. Um, they may understand the word but cannot say it. For instance, uh, say want water now. Instead, I want a glass of water. He just shortcut, cannot say, instead of I'm going to store to buy milk, say, me go store milk. Those, they omit small words like the and is and spirited, very able to mention. And some of them are this called the connection. I have a difficulty to name someone, name things, and say, what's the name? You know, naming is gone. I forget the naming and the connection between the goes through. Anyway, this is impairment-based therapy. Constraint is used the same as I mentioned, ask patient to name pictures, ask them to repeat words and follow command. Reading comprehension has to read. Tell me what's that about. You ask and say, today is a sunny day. Repeat that. Today is Sunday. It takes a while. Few people do they understand the command or understand but not able to speak. And then you have this speaking, avoiding gesture and say, you cannot communication as like when give me this Don't point, you just say, kick constraint. You're not able to do any gesture, any pointing, you just say, and then force that people, patients, to do their best and make progress. Okay, well, swallowing is a problem. Swallowing, we need to have the swallowing evaluation, able to get to X-ray, able to swallow fluid. Okay, the fluid is good, and then solid, swallow the solid, and so on. Most of people have difficulty if fluid than solid, and then you can see on live fluoroscopy also the food with contrast, so you can follow it and say, oh, it's poking it. It's stay here, or it's stay there, or it's swallow completely. Is there any aspiration getting to the lungs or so? It just it requires a lot of coordination. We have a video and watch live. And so that is the swallowing exercises. So people with stroke has a lot of risk of pneumonia because they have this aspiration quite open. And it be careful about that. Uh, the role of family, caregiver encouragement, communication support, and patience. This takes a long time. If you have a small victory, celebrate it. There's emotional support. People with stroke have frontal lobe issue, kind of get depressed, lost their function. They are need a lot of support for them, and communication issue, and facilitating the practice and encouragement. Um, Recovery, long term, it takes a while. As I mentioned, most of the recovery is happening within the next 3 months. Later on, it takes slow recovery. And key to take away from this therapy, stroke rehabilitation is need to start early. Take care of this neuroplasticity. The brain can adapt, can adjust, and function can take over different tasks, and you need to take advantage of that. Um, this is the same. Make sure that those who survived the stroke felt able to do meaningful activities. They are they will be need to take care of themselves as possible with minimum assistance at most. Um, uh, uh, they will. The aim is to maintain independence and quality of life. Prevention strategy primary is hypertension. Make sure blood pressure is controlled under 140. Diabetes is controlled, hemoglobin A1C below 7. Hyperlipidemia is controlled. Those are things that we need to work on because those kind of narrow the arteries. Lifestyle change, diet, exercise and smoking. If you smoke, I mean, time to stop smoking. Exercise will help the blood vessel to dilate, and need to have 150 minutes of exercise weekly. I really try to do that. I'm working, but they want to. If I'm smoking, I celebrate. I say, "Wow, I can eat again today." So, you know, fortunately, I'm now. Right now, I don't take any blood pressure medication or anything. Um, but it requires lots of motivation to it. Lots of motivation. Uh, Medication are the best. If you have high blood pressure, take blood pressure medication. Don't, this is a silent killer. And if you have a high lipidemia, take statin or whatever the doctor provides. Have a good health. Take good food. We talk about that, what type of food you need. Plant-based diet, fruit, vegetables are very helpful. There are some food that really help with antioxidant. We can talk more about that on Friday, but it's good. But they said we are what we eat. If we eat all of this carrot, go, um, broccoli, uh, pineapples, and so on, comes up. All of this, be careful, Uh, um, I believe it's sandwiches and uh, French fries and a good thing. I'm done. And so strategy is management, prevent recurrence. The first thing when you have this transient attack, there's a chance that it will come back again. Need to be on platelet, because you're okay. Diet is good. We don't want to have that stroke. If it's happening, it may be bigger than the first one. Um, do a follow up with the doctors and patient education. Uh, warn them about signs. If you have some, oh, I have my eyes kind of blurry one time, the fast face, arm, um, the speech, and then on one. Huh? Think about that. Lifestyle modification, we mentioned about that. And this is a cute phase. We don't do that in hospital, but uh, stroke, mobility, swallowing, continued trust strategies, and the summary and conclusion. Stroke is a medical emergency, require quick assessment, quick intervention, evaluation. There is a bleeding stroke. No, bloodless stroke, 87%, bleeding stroke, 30%. Time is brain. Early recognition of the sign is very critical. The treatment can be blood thinner, can be thrombectomy, removal of clot, and rehabilitation are always there. It is preventable. Early recognition and treatment is important. If some of your family has it, include physical therapy, occupational therapy, and rehabilitation. That saves life. That is the talk of today. I hope we learn something, and I hope we will not need to use it, but um, at least we are aware if someone has. Well, we can bring people if you like. We talk about back pain, treatment, and overview. What should we do and what the problem is? And we'll see you at 6:30. 6 is all I think. 6:30 you start. Very good. Good to see you.